Today, we're going to go over just a brief introduction to neurodegenerative diseases, focusing on clinical presentation and diagnosis. Before we dive in, I want to start by defining neurodegeneration. Neurodegeneration is a wide-reaching class of diseases that are common in that they are characterized by neurons losing function. I personally don't love this definition though, because I think it's just a little bit too broad. Instead, I prefer to define neurodegeneration as central nervous system cells losing function over time. Because we now know that neurons are not the only cell types that are affected by neurodegeneration, and that a defining feature of these diseases is progression over time. So, this is the definition that I want you to be holding in your mind as we go through this class together. Under this broad definition, there are several branches that distinguish smaller groups of families. We'll be introduced to four: tauopathies, synucleinopathies, trinucleotide repeats, and prion diseases. These families are named by the primary proteins that are seen in the diseases, which we will talk about in more detail in the next class. The commonality between all of these, of course, though, is CNS dysfunction and specifically the progression of CNS dysfunction. We, of course, don't have time to go through every single disease, but I did want to put this table up to show you how diseases you have probably heard of are categorized. We specifically are going to zoom in on only this top row here, which are the most common of each category. Even within this top row, I'm really going to spend the most time talking about these three: Alzheimer's disease, Parkinson's disease, and Huntington's disease. As I mentioned earlier, this class is going to focus on three questions. What do these diseases look like in the clinic? How are they diagnosed? And who is diagnosed? Importantly, though, extremely importantly, when these diseases are diagnosed is critical. This is a graph that shows how late these diseases are discovered. Along the bottom here, we see progression over time that includes normal aging, a prodromal phase, which is a preclinical or pre-symptomatic phase, and the clinical phase. This green line here is showing us the neuron density in a percentage. This red line here is showing us the severity of symptoms. The striking part of this graph is looking here at this point of intersection. When a person will appear in the clinic and be diagnosed at this intersection here, they will already have lost a significant amount of neurons and show widespread pathology. During our assigned class time, we'll talk a little bit about why this is problematic. But for now, we're going to focus on what leads to diagnosis. One more general note before we move on into specific diseases: none of these diseases, quote unquote, cause death. Rather, they are severely debilitating as people age, leading to less and less autonomy. Usually, near the end of life, the official cause of death will be an infection like pneumonia. Let's start with Alzheimer's disease, the most widespread and well-known neurodegenerative disease that is part of the family of diseases known as tauopathies. Alzheimer's is most associated with memory loss and confusion of time and place, but this is not only a disease of memory. Early in the disease, symptoms that typically lead to a person seeking medical attention include mood changes, social withdrawal, and difficulty communicating, in addition to the noticeable memory loss and confusion. This is really hard to self-identify though. Often, people see clinicians because their partner or a caregiver has expressed concern and brought them in to be tested. Once a person is in the clinic, the first step that is usually taken is a general memory assessment. There are a few, but a very common one is this one, the Mini Mental State Exam, or the MMSE. It's out of a total of 30 points and designed to assess attention, awareness, and memory in a few different capacities. This is a quick example of what it looks like, and it's really quick to administer, but we're not going to go into the details of the questions right now because I want to review this together during our synchronous class time. Anyone who scores above a 25, remember this is out of 30, on the test is considered to be cognitively fine. A score of 19 to 24 is considered mild cognitive impairment, or MCI. This MCI falls into the prodromal stage. And I just want to add a quick note that not everyone who is diagnosed with mild cognitive impairment will develop Alzheimer's disease. This is a period of time in which a person will be watched very closely by their doctors to see if they're about to cross the threshold into further cognitive decline or potentially stay steady at the state they are in. If a person is going to progress into full Alzheimer's disease, it will usually be about 7 years after identifying MCI. Once scores drop into the 11 to 19 range, this will be when a diagnosis of Alzheimer's disease occurs. Beyond that, then scores less than 10, patients will show further decline until end stages. This decline from Alzheimer's disease until death usually takes about 6 to 8 years. This is not the only way to diagnose Alzheimer's disease, though. Other tests will often be administered, such as the Mini Montreal Cognitive Assessment, or the MoCA, as well as biological measures collected, including blood tests and brain scans. However, nothing will fully determine Alzheimer's disease until a neuropathologist can look at a patient's brain after they die. So who is diagnosed with Alzheimer's disease? There are some very interesting trends. The first of which is that women are more likely to be diagnosed than men, at a rate of about 2 to 3 women per 1 man. This is something that is not totally understood, and we'll touch on it a few more times over the next 2 weeks. At this point in time, though, we don't have a good idea about what causes Alzheimer's disease. Age is the greatest known risk factor. The older you get, the more likely it is that you will be diagnosed. And here are some percentages broken down here. So for example, people who are in the 75 to 84 range have a 44% chance of being diagnosed with Alzheimer's disease. And this is around the age that most people are diagnosed. An interesting note is that anyone diagnosed at less than 65 years of age is considered to have early onset Alzheimer's disease. And these are usually caused by genetic mutations, which we will discuss later. However, the majority of cases have no known cause. A fairly new theory is that Alzheimer's disease is caused by viral infection. There has been evidence that the herpes virus entering the central nervous system can lead to Alzheimer's disease later in life, as well as evidence that people who annually get the flu shot are less likely to develop Alzheimer's disease. However, this is a fairly new idea that needs to be further investigated before we draw that causal line. I want to finish up by talking about a couple of the cases. So as you can see, in 2018, 5.7 million people had Alzheimer's disease, which is a lot. This is 2% of the entire population. By 2050, though, it's projected that this number will almost triple to be 14 million people, really highlighting how important it is to start to better understand this disease so that we can know where it comes from and how to better treat it. Alzheimer's or tauopathies are not the only neurodegenerative disease, though. Let's move into synucleinopathies, particularly Parkinson's disease. Parkinson's is the second most common neurodegenerative disease, but it looks very, very different than Alzheimer's. This schematic shows the common symptoms that are seen in a patient who has Parkinson's disease. You're probably familiar with the hallmark tremor, but you may not know that this is predominantly on one side of the body. Another major symptom that people are commonly aware of is the slowness of movement or muscle stiffness, called bradykinesia. This can be seen specifically in transitions from sitting to standing and as well as in a shuffling gait. Patients also typically show a stooped posture, apathetic facial expressions, very soft speech, and smaller handwriting, as well as a host of non-motor symptoms like depression, fatigue, constipation, and some of the others listed here. Now that's a pretty big laundry list of symptoms, but in the clinic, a physician will diagnose a patient based on two major symptoms. First is the presence of bradykinesia, the slowness of movement, and either rigidity, tremor, or postural instability. Bradykinesia is a must-have in order to diagnose Parkinson's disease. The other three are different presentations that can show up at different points for individuals. There is a whole motor test that people go through, which we'll walk through together in class on Monday. Usually, these patients will also go through the MMSE and the MoCA to assess cognitive function and rule out Alzheimer's disease. The time it takes to progress from original diagnosis to death in Parkinson's disease has quite a range. For some people, it can be up to 10 years, or it can be 10 years, while for others, it can be up to 20. In contrast to Alzheimer's disease, men are actually more likely to be diagnosed with Parkinson's disease than women, at a rate of about 1.5 men to 1 woman. Similar, though, to Alzheimer's, age is the greatest known risk factor to develop Parkinson's. There are very few known causes. Again, this early onset stage, so younger people, are usually caused by genetic mutations that we do know. But those are rare and only account for a very few diagnoses overall. Some other known causes include exposure to pesticides, such as paraquat, or toxic chemicals, such as MPTP. We'll talk more about those in our next class because they're slightly unique compared to the traditional Parkinson's cases. Diagnoses are increasing rapidly, just like with Alzheimer's disease. The most recent count of cases was right around 900,000 individuals in the United States and is projected to increase by about 3% in the next 10 years. Again, highlighting how important it is to figure out what exactly is going on in these diseases. The next disease we're going to review is Huntington's disease, which is the most common of the trinucleotide repeat family. Huntington's disease is a very severe and quick-acting disease once symptoms actually appear. I'm sure you can guess which of these two brains is from a Huntington's disease patient compared to an age-matched healthy control. You can see here very severe atrophy around the cortex and here in the striatum compared to the healthy control over here. Researchers and clinicians have categorized symptoms of this disease into three main categories. Cognitive, which affects learning and memory, attention, and executive function. Emotional, such as presentation of depression, anxiety, emotional disturbances, and motor. As with Parkinson's and Alzheimer's, brain atrophy affects nearly every aspect of brain functioning. But the hallmark symptom for Huntington's disease is the chorea, which is Latin for dancing. In a sense, you can think of Huntington's as exactly the opposite of Parkinson's. Patients suffer from uncontrollable movement to the point where they appear as if they're dancing. I will link a video to a patient on the D2L page, which we will likely review in class. Unlike Parkinson's and Alzheimer's, we actually know exactly what causes Huntington's disease. and people are diagnosed with a genetic test. This is an autosomal dominant mutation that involves excessive repeats of a trinucleotide sequence, hence the categorization in the family of trinucleotide repeat diseases. This schematic shows the normal Huntington gene, which we all have, and the mutated gene. On this gene, the mutant Huntington has a CAG section that repeats 40 or more times, leading to a protein that becomes misfolded, sticky, and toxic to cells. As I mentioned, this is an autosomal dominant disease, which means that men and women are diagnosed at equal rates. Just to do a quick review, let's take a look at what autosomal dominant means. Let's say a person with a normal Huntington gene, HTT, falls in love with a person with a mutated Huntington gene, this mHTT. If they were to have a child, there would be two possible outcomes. This Punnett square is showing those outcomes because remember, we all have two copies of each chromosome. We inherit one from each of our parents. Because this is autosomal dominant, a child that inherits just one copy of this mutated Huntington gene will develop Huntington's disease. There's no question about that. If you have the gene, you will have the disease. This, of course, can be devastating news and is something that genetic counselors will discuss with people often before they have children. One difficulty in this disease, though, is that often people will not show symptoms until they're about 40 years old. So sometimes people will be unaware that they carry this gene until after they have children. More is known at this point in time, and there is more easily available testing for people. So we will hopefully be able to get this a little more under control. To wrap up this first lesson, here is a table that compares these three diseases we just talked about based on their major diagnostic symptom, the major cause, if we know, the method in which a clinician will diagnose this disease, and the female to male ratio for diagnosis. So when we're thinking about these three diseases, Alzheimer's is primarily a cognitive disease. Parkinson's is characterized by motor impairments that are hypokinetic, so a lack of movement. And Huntington's disease is a motor impairment that is hyperkinetic or too much movement. Alzheimer's and Parkinson's both are primarily caused by age, whereas Huntington's disease is entirely genetic. And diagnoses of Alzheimer's and Parkinson's are based on clinical symptoms, while Huntington's disease can be determined with a genetic test. In our next lesson, we'll go over the neuropathology and neuroanatomy that is associated with these diseases, focusing on the characterizing proteins and brain regions that lead to symptom presentation and the progressive decline.